The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, everyone, and welcome to another edition of Question Lab. We are very happy to have all of you here with us tonight as we focus on a set of challenging Step 1 questions related to hematology and oncology. We're happy you're here. Get ready to engage, learn, and challenge yourself. And I do believe that Abraham is here. Dr. Titus, are you out there?
Yes, I am. Sorry about the delay. My computer decided to restart. Okay, my name is Dr. Abraham Titus. I'm a Hematology Oncology Fellow at the University of South Alabama. I've been a tutor with Scholar RX for a few years now, and I've taught many students such as yourself for Step 1, Step 2, and even Step 3. And I'm excited to be here and talk a little bit about my specialty, Hemonc.
Okay, so you've met us, and now we'd like to learn a little bit about you. So what we're going to do is we're going to launch the first poll of the evening, and it's the simplest question you're going to get tonight. Who are you? Are you an M1, M2, M3, M4, or are you an IMG or a foreign medical graduate? Let us know. Kind of helps us kind of calibrate our approach. But more importantly, we love to know who's out there, who's taking part. You know, it's kind of, this is the time of year where I know some of you may be in serious step prep mode. Some of you may be taking some time off for the summer and just trying to stay sharp. So regardless of why you're here, we're happy you joined us. So basically, we use the quick poll throughout the evening. This is how you can answer the questions. And once about 75% of you have answered, we'll close the polls and share the results. So with that, let's go ahead and close the poll and see who is here. So we have got a strong contingent of IMGs and FMGs, almost 2/3 of you. We've also got quite a few M2s in the house. We've got some M3s as well as a smattering of M1s and M4s. So we are really we're happy to see all of you, and we hope that you get a lot out of tonight's session. So again, you know, we've been doing Question Lab for a long time. Question Lab actually, sprouted at the beginning of the pandemic back in 2020, and we have these regular sessions designed to, help students as they prepare for, whether it's for self-assessments or for their board exams. And part of what we want to do is, not only, it's not just about helping you with the content, right? You already have a lot of that knowledge. A lot of this is stuff that you've learned or are learning. But above and beyond that, we really want to help you so that when you walk into that Prometric Center or when you walk into your exam center, that you're confident in your ability to take on these questions. Especially because it is it's an event. It is it's a grueling, mentally taxing, emotionally exhausting day, right? And so it's always good to have a process, and that's what we like to emphasize here. So as we go through this, we're going to talk about some of the steps that we recommend when you are going through these questions. Maybe you already have a process, which is great. If you don't have a methodology, you can feel free to adopt ours. But what we're going to do is we're just going to, tell you how we do it and why. And then, if this helps you, all the better. Okay. So we got 4 questions tonight. Here's the first question. And the one thing you're going to notice right off the bat, there's something missing. And those are the answer choices, right? That's by design. We feel like the first step you should do is you should cover up the answer choices. And the reason we suggest that is that you're going to see a lot of answer options on on test day, right? You're gonna see, who knows, probably over 1,500 answer choices, and some of those are going to be things that you do not know very well, or some things that you've struggled with. And what we want you to do is just focus. And so part of it is we ask you to, first thing to do is like cover up the answer choices so that you don't freak yourself out. And then the second step is read the lead in, right? Read the actual question. Um, you know, and the reason here is that you want to know what it is you're trying to solve. You want to know what it is, the problem that you need to figure out. And we think that by reading the lead in, now you are in a much better position to actually go into the vignette. So let's read the lead in. Which of the following is the most likely underlying cause of this patient's symptoms? Okay, so reason you read that lead in first is, every now and then you can actually answer a question just by reading the lead in. You don't even need the story. You don't even need the scenario. But the other thing is, it's like, these vignettes get long, right? So, you're going to get overwhelmed in some cases with all kinds of information, and some of it is important, some of it's not so important. So reading the lead in helps you kind of sift and sort that information and figure out what is important. Okay, so we've read the lead in. Let's go ahead and read the vignette. A 65-year-old woman is brought to the emergency department with fever, confusion, and headache. Physical examination reveals lower limb weakness and multiple punctate red lesions on the inside of her mouth. Platelet count is 10,000 and serum creatinine level is 6.3. A blood smear is shown. So again, the question, which of the following is the most likely underlying cause of this patient's symptoms? Think about how many steps it will take to solve this one, and put it down there in the question box as I turn it over to Abraham.
All right, thank you, Jeff. So as Jeff mentioned, we do always have to read the lead in first. That's the most important thing. And we want to also look at any kind of images associated with it and just to have a general idea of what we're looking for. This question, the vignette's not that big, so it's not too bad, but a lot of questions you realize the vignette is huge. And you don't want to get overwhelmed, you don't want to get lost in reading it. If you know what the question is asking, you can already start picking it out as you read through it. So let's highlight some of the keywords here, and let's go through what we are actually doing, and let's read this in a smarter way. Which of the following is most likely underlying cause of the patient's symptoms? So it's not asking about the diagnosis, it's asking about the underlying cause of the diagnosis. Okay, we have a 65-year-old woman. I always like to think about age and sex. That's a very important thing to help kind of build a mental picture of the patient in your mind. And think about symptoms: fever, confusion, and headache. Okay, those are some kind of non-specific symptoms, but maybe some clues there. Lower limb weakness and multiple punctate red lesions. Okay, what could those punctate red lesions be, and why is she having weakness? And the punctate lesions are in the mouth. Okay, fine. Platelets are 10,000, so that's low, right? You don't always have to memorize your lab values. You do always have that reference, but it does speed up sometimes if you can kind of know generally where certain these labs land. And creatinine is 6.3, and no one needs to say that's an abnormal number, right? You want that close to the 1 mark. So you have something that's causing a creatinine elevation, something that's causing a platelet dysfunction or a deficiency, and you have this neurological features with these punctate things. There's a fever involved. And then last but not least, the biggest clue in this question is this peripheral smear they're giving us. I don't want to give too many clues here, but there are certain types of cells that are present in this smear that you guys should be recognizing, and just look at it and then try to connect that to the story. A lot of the times they're not asking you to be a pathologist. You don't need to diagnose it just from the smear, but look at the vignette, combine it with the smear, and then you can put the two puzzle pieces together and come up with a diagnosis. So I want you guys to take your time, think about this, think about what the diagnosis is, and think about what could be the underlying cause of that diagnosis. That's how you want to approach this question. All right. And let's look at some of the options and let's break this down. So we have option A, abnormal high blood ammonia levels. Option B, an immune attack against platelet surface antigens. Option C, antibodies directed against ADAM TS13 metalloproteinase. Option D, erythrocyte that contain denatured hemoglobin. And option E, long-standing hypertension. Now, each of these are an important concept, and they are different diagnoses. So, even if you don't get the question right, I still want you to think about what each of these are. And even if you know exactly what this is, I want you to think about what each of these other options are pointing at and what they're trying to really get at with this. So think about this, and I want you guys to commit to an answer and pick one.
Okay, well, let's hide the results and reveal the answer. And the answer is answer choice C. Antibodies directed against the ADAMTS13 metalloprotease. Well done. Good job here, everyone. Good way to start out tonight's question lab. If you didn't get this, and about half of you didn't, that's okay. That's why we're here. So we're going to walk through this one with Abraham.
Awesome. Great job, guys. Again, not a very easy question, but also not the hardest question, right? So the most important thing here is coming up with the diagnosis. Don't feel bad about getting it wrong. This is hematology oncology, definitely a tougher subject for a lot of students, but when you think about the breakdown of the exam, there is a lot of heme on the exam. So you guys want to feel very comfortable, especially with the heme aspect and the path aspect of the heme. Okay, so let's break this down. So we got a 65-year-old woman. Okay, what symptoms does she have? So she has fever. She's got this confusion and these neurological symptoms. Okay, that doesn't explain. And then what am I looking at on the smear? Look at these cells that look kind of like helmets, or they look like they've been sheared through. These are called schistocytes, right? These RBCs that are kind of these crescent shapes, or like not creating the full nice biconcave shape we like to see. It looks like they've been ripped up into shreds. Those are called schistocytes. And those indicate that we have some kind of process that's causing these RBCs to be sheared as they pass through the blood vessels. And these category of blood conditions that cause these schistocytes are called MAHA, microangiopathic hemolytic anemias. MAHAs, whenever I see a low platelets with a low hemoglobin, I have to make sure it's not a MAHA. My MAHAs are going to be my DIC, my TTP, and my HUS. And in this situation, with her having fever, having neurological dysfunction, and that kidney injury, all that should point towards a condition called TTP. TTP has something called a pentad, right? That's how you diagnose TTP. These 5 things generally have to be present, not all of them all the time, but you want to look for these. And on exam purposes, they'll typically give you all 5. It's going to be fever, anemia, thrombocytopenia, renal failure, and neurological disturbances. So it can be any kind of neurological disturbance, but in this situation, they're giving you this like leg weakness that they're giving you. Okay, what are the other clues then in this question? Well, the creatinine elevation they're giving you, the platelet count going down is another big clue. And when you look at the other options, they don't really fit. What does high blood ammonia levels mean? Well, that typically means liver failure, right? Hepatic encephalopathy. So having liver failure can cause some issues, but it wouldn't cause schistocytes. It wouldn't cause you to have these neurological dysfunctions. If anything, it would cause hepatic encephalopathy. So confusion, tremors, that's the kind of story they'll give you. A lot of you guys picked option B, which is a good option as well. But having immunoglobulins attack platelets is a condition called ITP, immune thrombocytopenic purpura, or idiopathic thrombocytopenic purpura, where it's just the only problem I'm going to see is low platelet count. So ITP is, think of it as like a baby version of TTP. TTP is the big bad, and ITP is the small. ITP, all you will see is low platelets, no kidney dysfunction, no neurologicals, no fevers. TTP is the big bad one. That's a scary one. If you don't treat, they're going to die. So what are these ADAMTS metalloprotease? That's like the big thing that everyone confuses people. Metalloprotease is just a protease. It means that it cuts things up. ADAMTS13 is a specific protease which breaks down von Willebrand factor. And as we know from previous studies, von Willebrand factor helps these platelets clot. Okay, they cause adhesion of the platelets and start the platelet plug. I don't want to go too much into detail, but if I'm not cutting up these von Willebrands into small little pieces, and they're giant pieces of von Willebrand, which I'm not cutting up and making it into useful small pieces, they're just going to cause clots for no reason. And that's what's going on. The problem is this ADAMTS13 is not cutting up von Willebrand. Von Willebrand is too big. The too big von Willebrand factor causes too many clots. Too many clots breaks up the RBCs in the bloodstream and also causes damage to the kidney. So it's a downstream effect that causes a whole cascade of events. And the neurological features are also associated with it. Option D, erythrocytes that contain denatured protein, is G6PD. It's the denatured hemoglobin that comes from free radical damage from different things like fava beans, sulfa drugs, TB drugs, things like that. And long-standing hypertension, again, if you have real bad hypertension, that can cause neurological features and stroke, but that's not what's going on here. Here, they give you these cystocytes. They give you this thrombocytopenia. So think more than just hypertension. So great job, guys. Lots of little details in this question, and they can ask this in many, many different ways. TTP is one of the most high yield things you need to understand.
Well, very good. Thank you, Abraham. And yes, a good start for everybody here, and lots of good high yield snippets from Abraham to take with you. So we're on to question 2. Now, some of you, if you got in here late, we had some technical difficulties here at the beginning, so we may be running over the top of the hour. So just brace yourself. But anyway, we're ready for question number 2. Again, we have covered up all of those answer choices. We've got another graphic here. So again, we start by reading the lead-in. Underproduction of which of the following molecules is most likely responsible for this patient's reaction to the drug? Okay, so with that lead in, now you already know what kind of question this is and what you're going to be focusing on, and you know that you're most likely going to be needing to lean on the image provided in the question. So with that, let's go ahead and read the vignette. A 36-year-old man comes to the clinic with fatigue and shortness of breath. He was prescribed trimethoprim sulfamethoxazole for a urinary tract infection 3 days ago. Physical examination is notable for the findings shown in the image. He has a hematocrit of 28% with a mean corpuscular volume of 85. So again, underproduction of which of the following molecules is most likely responsible for this patient's reaction to the drug? Go on and head down to the question box. Let us know how many steps you think it'll take to solve this one while I turn it over to Abraham.
All right. Another great question here. Image is important, but really only one key thing is eyes are yellow. Like that's the big clue I want you to take from this image, right? So let's break down this question. Let's look at what the highlighted keywords are in this question, and let's try to figure out what's going on. Again, the lead in here is saying underproduction of which of the following molecules is likely responsible. Underproduction is high yield, and understanding the mechanism by which this condition is happening is what's important in this question. So you have to obviously get the diagnosis first, then you got to think, okay, what is being underproduced in this diagnosis, okay? So let's break it down. 36-year-old man, okay, you want to think about what kind of patient we're dealing with here. Fatigue, shortness of breath, and like very broad, like non-specific symptoms. But he was prescribed trimethoprim sulfamethoxazole, TMP SMX, right? We love that drug. We use it a lot. Used 3 days ago for a UTI. Now, then he presents with the image. So he's got these yellow eyes. What does the yellow eyes mean? What does it indicate? You got to think a couple things when you oversee these kind of patients that come like this. And he has a hematocrit of 28%. So we don't have the labs here, but that's low. And his MCV is 85. Why do they want to give us MCV? That's a normal MCV. 80 to 100 is what I'm thinking about when I think of a normal MCV. So you have a normocytic anemia that's happening in this situation with this guy with yellow eyes, recent antibiotic exposure, and they're asking underproduction of what of the following molecules occurred. Think about the diagnosis. I want you guys to think about what happens in that diagnosis. And then what step 1 loves to ask is the mechanism behind things, and like think about the molecules that are happening on a microscopic level. So let's look at the options here and let's go through them and let's try to pick the best answer. Okay, option A, glucose 6-phosphate. Option B, phosphoribosyl pyrophosphate. Option C, reactive oxygen species. Option D, reduced glutathione. And option E, tetrahydrofolate. So lots of good options here. There are some tricks in this question, and I want you to kind of think about what the diagnosis is and really don't rush the options. Try to look at each option, try to see what makes the most sense to you. Obviously, if you have a gut feeling, always stick with your gut, and that's probably the correct answer. But I want you to kind of make sure you read all the options before picking an answer. Take your time and let's look at these options and pick what you guys feel is the most correct answer.
Okay, so the poll has been launched. So go ahead, take a look, choose the molecules that you think, the underproduction of which is most likely responsible for this patient's reaction. So looking at this, about 2 out of 5 of you went with answer choice D, reduced glutathione, whereas almost a third of you went with glucose 6-phosphate. Those numbers were fluctuating, so at one point the gap between them was a bit smaller. And about 20% of you went with answer choice E, tetrahydrofolate. So let's see how we did here. So I'm going to hide the results and go ahead and reveal the answer. And the answer is answer choice D, reduced glutathione. So great job, everybody. We are now 2 for 2. And as is often the case here in Question Lab, not as many people got this one right as got the first one. Sometimes the difficulty levels will increase, but that's okay. You guys performed well. If you didn't get this one, for whatever reason, we're gonna figure that out right now when I pass it over to Abraham.
All right, great job, guys. So don't feel bad if you guys picked A or E. They're both good options. You got to think about this a little bit more detail, right? So let's think about what the underlying diagnosis is first of all. So this guy got exposed to a sulfa drug, right? TMP-SMX is a sulfa drug. And then he came in with jaundice, yellow eyes, typically think jaundice. So when you guys see jaundice, I want you guys to think either it's a problem due to hemolytic anemia or some kind of destruction of RBCs causing hemolysis that leads to the jaundice, or there's a liver/biliary tree, something else wrong with there. Okay, so it's either a problem, my problem's conjugating bilirubin and getting it out, or I'm just destroying too many RBCs where my bilirubin is just dumping into my blood. So that's one of what's going on. But with the anemia and normocytic, you got to think, okay, there's some hemolysis going on. So he took a trimethoprim sulfamethoxazole, TMP-SMX, and then developed this hemolytic anemia. So what's that connection there? And that's what's high yield in this question. Okay. A couple important things here. So you may notice his patient's African American. That's another clue that they gave you with the picture. And the other big clue in this question is that what's going on? If I diagnose this guy with G6PD deficiency. Now, this is the trap that a lot of students make, and this is a trap that they purposely do, so you kind of get stuck. Option A is not G6PD deficiency. That's just a deficiency of glucose 6-phosphate. You want a deficiency of glucose 6-phosphate dehydrogenase deficiency. So that is the trap. Okay, that's why I see that you got a lot of picked A, so I think you guys all were considering G6PD in that picture. But G6P is not what's causing G6PD deficiency, right? What causes this hemolysis when exposed to fava beans or when exposed to sulfa drugs or malaria drugs is glucose 6-phosphate dehydrogenase deficiency. That's the trap. And option E, I also understand why you guys picked that, right? TMP-SMX blocks folate. It makes sense why you would be anemic. But if I was causing that blockage of folate, instead of causing a hemolytic normocytic anemia like he has, you would get a macrocytic or a megaloblastic anemia where the MCV would be high and you have the anemia. And that would happen after a little while. It wouldn't happen right after getting exposure to the drug. So option A and E are both the big traps that they set out for you guys. And definitely, if you made that mistake, that's okay. You learn from that. You understand that G6PD deficiency is glucose 6-phosphate dehydrogenase deficiency. But D in the end does not stand for deficiency. That's like I always tell my students that. All right, what happens? Well, reactive oxygen species are involved, but they're actually increased, right? When you have G6PD deficiency, our body's ability to protect our RBCs from these free radicals go down. Our ability to make glutathione goes down. Reduced glutathione is an antioxidant. It's something that our RBCs have as a shield to protect itself from these reactive oxygen species floating around. And patients that already have a G6PD deficiency will have a reduced ability to protect themselves from these free radicals. So whatever it is, if they get sick, if they're starving, if they're taking sulfa drugs, if they're eating fava beans, if they're going on a big hike. A lot of these things will cause free radicals to increase in our body. And me and you, when we don't have G6PD, our body's ability to compensate for that high free radicals is okay because we have that enzyme that can make reduced glutathione, that can protect our RBCs from that hemolysis. But patients that do not have that enzyme, do not have G6PD, cannot reduce my glutathione. So I don't have that antioxidant ability. Therefore, these free radicals cause tons of damage, create Heinz bodies by denaturing hemoglobin, destroy RBCs both in the intravascular space and the extravascular space, and lead to hemolytic anemia. And that is what's going on in the situation. That is why D is the correct answer.
Okay, excellent. Again, some hardcore hematology here. So hopefully you've been taking notes and you're drilling some of this stuff into your head. So great job, everybody. We've reached the halfway mark of tonight's event. So time for a quick stretch break. And while you're stretching, standing up, we just want to talk a little bit about USMLE-Rx. As most of you know, Rx offers a absolutely comprehensive suite of tools designed specifically for you, for med students, including the QMAX question bank, our high yield RX bricks. We've got our flash fact system with over 13,000 cards and the study stream spaced repetition system built in, and over 1,300 step 1 express videos. So whether you're starting out on your test prep, I know we've got some M1s here, or if you're looking for put the finishing touches on before your exam, Rx has everything you need to succeed. We got a couple of quotes from students, and again, the great thing about Question Lab is we have students from around the world, and we also have students from around the world using Rx. So we'll talk about this at the end of the evening, but we do have a special 30% off discount running through Thursday night. So again, perfect opportunity to get access to all of the resources, all of these integrated resources, and to do it at a fantastic price. So don't miss out on that. So again, appreciate your attention. And now let's get back to slicing and dicing these hematology and oncology questions. And we're going to go to question number 3. Again, we've got 4 questions tonight. So this is question 3. At the end of the event, we're going to draw the name of one lucky winner who will get an RX 360 Plus subscription. So hang in there. So again, what do we do? First thing we do, we cover up those answer choices. The second thing we do is we read the lead-in. So let's do that right now. Decreased levels or activity of which of the following enzymes is the most likely cause of this patient's symptoms? Okay, so again, we know we're going to be thinking about identifying the right enzyme, and we know that we're going to have to figure out what might be causing the symptoms that we're going to read about. Okay, so with that, you've got some good context to hang your hat on. So let's go ahead and read the vignette. A 27-year-old male is brought to the emergency department in an agitated state. He complains of severe abdominal pain that started an hour ago, shortly after a dinner party with friends. During the assessment, he becomes paranoid and combative, requiring 5-point restraints. He has no history of major medical illness. His temperature is 37.2, pulse is 110, respiratory rate is 20, and blood pressure is 138/92. Physical examination reveals mild diaphoresis. The blood alcohol level is elevated. When a straight catheter is inserted, reddish urine flows into the Foley bag. The urinalysis is negative for heme and proteinuria and has no cells. So again, decreased levels or activity of which of the following enzymes is the most likely cause of this patient's symptoms? Head on down to that question box. Let us know how many steps you think this is. A 1-step question, 2-step, 3-step, as I pass it over to Abraham.
Thank you, Jeff. All right, so we got a little bit of a different question here. We got a younger patient, and we're dealing with somebody who is presenting with a unique situation, right? He just came from partying, what's going on? Let's highlight some of the keywords here and let's try to figure out what's going on in this situation. So again, let's read the lead in again. So decreased levels of or activity of which the following enzymes is most likely caused. So it's not just asking diagnosis, right? So step one loves multi-step questions. So it's not just diagnosis, it's about what enzyme is either deficient or the activity is not as much that's causing all of this to happen. All right, and looking at this picture, we got a young patient, so that kind of should give you a clue, 27-year-old male, and he's agitated. You know, what's causing him to be so agitated? He's also having abdominal pain, right? So there's a combination that's kind of interesting, agitated and abdominal pain. And he had a dinner party recently, became paranoid, combative, and we don't know why, right? Otherwise, he's not febrile, a little tachycardic because he's agitated, breathing fast, blood pressure's okay, nothing else is fine, but his blood alcohol level is elevated. Okay, does alcohol really make you have severe abdominal pain and paranoid and combative? Well, there's something else going on here. Well, another very important thing is that his urine is red as it flows into the Foley bag. So there's a weird combination of this. And then when they look at the actual urine, it's not heme, it's not protein, and it's not MSLs. That's weird. So why is it red in the first place? So we have this red urine, this abdominal pain, and this paranoid combative guy. And he recently just went to a dinner party and had some alcohol. So that's a interesting one. And this is like one that if you saw in the hospital, you'd be kind of very confused about what's going on with this guy. And this is when the basic science and understanding the step one knowledge will really come in handy if you think about this as a differential. And you'd really impress a lot of your attendings if you thought of this one. So let's think about what's going on here. Again, this is a tougher question than the last one, but I believe in you guys. You guys can try to figure out what's going on and then not only figure out the diagnosis, think about decreased activity with the following enzymes is causing this. So let's look at some of the options. Maybe it can give you a clue if you guys are completely lost, but let's look at this and let's try to figure out what we're dealing with here. So we got option A, alcohol dehydrogenase. Option B, amino-levulinate dehydrogenase, or ALA dehydrogenase. C, amino-levulinic synthetase. Option D, ferrochelatase. And option E, porphobilinogen deaminase. So a bunch of fancy terms. This is like one of those tougher questions in heme where it kind of dips its foot into the biochem story, and it's a multi-system question. But nonetheless, this is an important one, and this is a concept in step one they always test. You want to be familiar with this concept, and really, once you get it down one time properly, you won't forget it. So let's think about what this could be. Let's think about what the diagnosis is, and let's try to come up with which of the following enzymes, all these are enzymes, they end in A's, is deficient or the activity is low.
Okay, so let's close it, share the results, and almost 40% of you went with answer choice E, the porphobilinogen deaminase. There's some terms tonight that I have not I've not spoken out loud in a long time. And then in second place, alcohol dehydrogenase. So and about kind of a split for the third place vote between answer choices B and C. So with that, let's go ahead and hide the results, and we're going to reveal the answer. And the answer is answer choice E, porphobilinogen deaminase. So guys, we are 3 for 3. Kudos. You guys are doing really well tonight. So very impressed. But this is a tough one, and most of you didn't get it right. So we don't want to rest on our laurels here. So if you didn't get it, that's okay. Abraham is going to help you figure it out.
All right, great job, guys. Again, if you didn't get this one, not a problem. This is a tough question. This is one of the harder ones in heme, but also in biochem, right? It's one of those questions that dips its toe into both topics. Multi-system questions is always a favorite on boards. So you have to remember those. All right, so let's break this down. Let's figure out what's going on, and let's come up with a diagnosis. Right, so this guy has otherwise healthy young guy comes in, and he just drank a little bit of alcohol. They don't say how much, but he went to a dinner party. And then he just starts getting super combative. He has this red urine and this abdominal pain. That's kind of a triad you kind of want to look for: paranoia, agitation in a young patient with exposure to alcohol, especially with this red urine picture. You want to think of some of the porphyrias. And we're dealing with the porphyria. This is like how our body makes heme. Whenever there's issues with the enzymes that make heme, we can lead to a bunch of different disorders, right? So there is acute intermittent porphyria, porphyria cutanea tarda, sideroblastic anemia. All these fall under the category of different ways our body kind of has a pathology where it doesn't make heme properly. So an important concept in this question is understanding that porphobilinogen deaminase deficiency leads to a condition called acute intermittent porphyria. It's one of the most important steps in between when we're making heme, where if we have that deficient, we start accumulating a bunch of porphobilinogen in our body. Right? Our body's not able to convert porphobilinogen into its breakdown product. And that leads to this triad of symptoms of having red urine, abdominal pain, confusion, especially triggered by alcohol or starvation. That's going to be the big clue there. Okay. Well, I'm going to go through the rest of these options here as well. And then I think I have a flow chart here just kind of helping you a quick understanding of that as well. So alcohol dehydrogenase, again, what does that cause? Well, alcohol dehydrogenase, job is to metabolize ethanol. It's going to convert ethanol to acetaldehyde. And even though just him having high alcohol level, that shouldn't cause something like this to happen. And that's not a trigger for AIN. Option B and C are both also part of the heme synthesis pathway, and they both lead to different conditions. ALA dehydratase can be seen in lead poisoning. Lead can actually block that. And ALA synthase can be seen in sideroblastic anemias, and that can lead to different types of anemias. And I guess it's kind of really complicated there, but just have to know the big picture. For you, what you have to know is acute intermittent porphyria. You want to think about porphobilinogen deaminase. How do they present? Abdominal pain, neurological symptoms, red urine. That's it. Ferrochelatase is another one that's blocked by lead poisoning, and this is the chart that I'm talking about. Very good chart, worth looking over. It's straight out of first aid as well, and you want to make sure you guys really familiarize yourself with this because they ask questions about all these. Lead poisoning works in two areas. We're on ferrochelatase and ALA dehydratase, right? That's what this aminoglybulinate. I just call it ALA, simple enough. Just recognize that. Whereas the sideroblastic is the synthase, or B6 deficiency can also lead to that. So the first column there, or first row there. Then if I look at the third row, porphobilinogen deaminase, I'm thinking AIN, acute intermittent porphyria. That's the one we're talking about. And then the last one here is uroporphyllinogen decarboxylase. Again, these are big fancy words, but if you just like use them as trigger words and connect these things together and associate, okay, acute intermittent porphyria with this enzyme, uroporphyllinogen decarboxylase with porphyria cutanea tarda. And that's the one where you kind of have really bad sun sensitivity. And you get like, as soon as sun exposure, you get blistering of your skin. And the name gives it away, cutanea tarda, cutaneous skin lesions, and it's a porphyria. Okay, high yield chart here, definitely worth taking your time going through this and feeling comfortable with this concept. Okay, don't worry if you got this one wrong, another hard question, but this is just a reminder that you should go back and look at your porphyrias. Lots of questions from here. And understanding, another question I got a lot was actually that glycine is the amino acid responsible for making heme. That's going back to biochem again. They like that question as well. So you may notice something. They just, if you know this chart, you'll get by with a lot of those questions.
Okay, excellent.
That's it for this one, yeah.
Okay, so thank you, Abraham. Great explanation, great breakdown. Keep in mind that we record all of our question labs, and you'll be able to rewatch this on YouTube starting sometime tomorrow. But no, a lot of good things that you need to be able to commit to memory. Okay, so with that, we have reached our final question of the night, question number 4. So we're going to see if we can actually hit for the cycle here, or clear the bases, or hit a grand slam. I don't know. We're just gonna waste a bunch of terrible sports analogies in seeing whether we can have a clean sweep, go 4 for 4. But it's we're not saying it's going to be easy. So let's go ahead and reveal the final question. Again, we will have a drawing here at the end of the evening, so that's going to be coming up. So once again, look at the landscape here. We have covered up the answer choices, but you can see that there's a lot in front of us, right? We've got a blood smear. We've got a lot of lab results. So let's go ahead and start with the lead-in. Which of the following complications is most associated with this patient's most likely disease? Okay, so there's a lot, compressed into that question. So with that, you kind of know a little bit about what you're going to be looking for. Obviously, you got the blood smear there, so you know that that's most likely going to be, crucial in solving this one, and that you know that you're going to be looking for a complication. So with that, let's go ahead and read the vignette. A 64-year-old male comes to his physician because of a 3-month history of lethargy and cough with brownish sputum. He has been treated twice in the past 3 months for community-acquired pneumonia. Temperature is 39.1. Physical examination is significant for right-sided pulmonary crackles, non-tender cervical and axillary lymphadenopathy, and hepatosplenomegaly. Lab studies show the following. Leukocyte count 40,000, neutrophils 20%, lymphocytes 77%, eosinophils 1%, monocytes 1.5%, basophils 0.5%, hemoglobin 8.2, platelet count 190,000, and the image of his blood smear is shown. So once more, the question, which of the following complications is most associated with this patient's most likely disease? Would love it if you'd head down to the question box and take a shot. Let us know how many steps you think this question is going to require you to solve. Is this a 1-step, 2-step, 3-step? As I pass it over to Abraham.
Awesome. All right. Thank you, Jeff. So again, tough question here, but we're going to break this down. We're going to go through this and we're going to look at the smear and we're going to figure out what's going on here. So again, let's think about what the question is asking. You use the lead in to help us read through this question. So let us first highlight some of the keywords. Let's find out what's important in this question. Let's break that down. So so first of all, which of the following complications are most associated with the likely disease? So not only knowing the disease, but think about the complication associated with this. I want to talk about the smear in a minute, but let's read the vignette. Let's get an idea of what the patient has and why they're coming in. You got the 64-year-old male, so not very old, but older gentleman. 3-month history of lethargy, cough, and brownish sputum. Okay, so that could be a few things. And in the past 3 months, he had pneumonia. Okay, he's been fighting pneumonia for 3 months. He has a fever and right-sided pulmonary crackles. Right, pneumonia is typically you just get it and you treat it and you're done. Why is he getting pneumonia for 3 months? And then they just kind of describe some of the things you see in pneumonia, right-sided pulmonary crackles. Non-tender cervical and axillary lymphadenopathy. Why is it non-tender? Shouldn't an infection cause tender lymphadenopathy? And hepatosplenomegaly. That's weird. Pneumonia shouldn't cause hepatosplenomegaly. So is there something else going on in addition to the pneumonia? And that's what your mind should be thinking about here. The physical exam is always very important, and especially when they give you key things, there's a reason why they give it to you. And just as important as physical exam, labs are just as important in heme and onc. We have a white count of 40,000. Okay, 40,000 white count could be because of many different things. Mainly lymphocytes. 77 of those, 40,000, are lymphocytes. What do we know about lymphocytes? When do we use lymphocytes? Think about that. The rest of it, sure. Hemoglobin is low. There's an anemia going on as well, 8.2. Platelet count's okay, over 150. We're good. And we have this smear. So you got this guy with the high lymphocyte count and anemia. You have history of infection with pneumonia. You have these lymph nodes that are swelling that are non-tender and a hepatosplenomegaly. If I'm looking at the smear, there's a big clue pointing in that picture. And this is a picture that you want to be able to recognize, and this is a very buzzword-worthy picture for you. I'm not going to give you exactly what you're going to see here, but focus a little bit on the white cells in there. There's something weird about some of the white cells and how they look. RBCs look okay to me, but what about those white cells? All right, so let us think about what's going on here. Let's break down the situation and really think about what the diagnosis is. Again, that's step one. And then you got to think about what the complication that the patient could be having that's causing this picture right now, that's causing this overall story. So let's look at the options and let's break it down. All right, so we got another 5 options here, high yield options, and each of them are associated with different things we'll talk about as well. Option A, autoimmune hemolytic anemia. Option B, autoinfarction of the spleen. Option C, disseminated intravascular coagulation. Option D, lytic bone lesions. Option E, progression to blast crisis. Okay, so we got some good options here. Each of them means something different and different conditions associated with them. And it's very good, even if you don't get this question right, to know what each of these options mean, as they're all high yield, highly testable topics. So take a second, read through it one more time, think about the things that are highlighted, and try to come up with a diagnosis and think about what complication that patient could be having.
So what I'm going to do is I'm going to get ready to close the poll and share the results. So let's go ahead and do that right now. And let's see what we have here. So again, 40% of you went with answer choice E, progression to blast crisis. And then all of the other votes were somewhere between 14 and 17%. So, so no, none of these were clearly ruled out by the audience tonight. And yeah, we have a big vote getter here, but let's see how that turned out. So I'm going to go ahead, hide the results, and let's reveal the answer to question number 4. And the answer is answer choice A, autoimmune hemolytic anemia. So again, this happens, and we did, strategically place the toughest question here at the end of the evening. But there's obviously a lot going on in that question, and there are some great teaching points here. So what we're going to do is pass it over to Abraham to help everyone kind of understand what was going on in this question and how you get to this correct answer. Abraham.
All right. So don't worry, guys. That was a tough question, and it's okay that you guys got it wrong. And that just means that it's such a learning opportunity for you guys. You guys found something that you guys aren't exactly sure about how to handle, and that's the whole goal of these things. Now, I feel partly responsible because I told you guys to focus on the white cells in the image, and that may have pointed you guys more towards the blast crisis as an option. But the big thing I was trying to get you guys focused on is these like smudge-looking cells, right? You see these like white blood cells that just look like kind of faded and kind of squished? Those are called smudge cells, and that's really the big clue in this question, right? You have this older gentleman that has this pneumonia that's not going away, keeps getting pneumonia, and then non-tender lymph nodes, right? Non-tender lymph nodes, when I think infection, I want to think tender. When I think cancer, I want to think non-tender, right? So this is pointing more towards the cancer picture, all right? With the hepatosplenomegaly, that all fits. And it's primarily all lymphocytes, right? They didn't mention anything about blast cells. They didn't mention anything about lymphoblasts or myeloblasts, right? Unless they're giving you blast cells, you shouldn't really be going down the blast crisis picture. If he had a blast episode for 3 months, he wouldn't be alive right now. He needs to treatment right. That's the kind of how aggressive those blast cells can be. So you need to look at this picture and look at it as like a chronic 3-month event that's happening. And when I'm seeing these smudge cells in my smear associated with these high lymphocytes and associated with these recurrent infections and non-tender lymph nodes, the diagnosis in this patient is CLL, chronic lymphocytic leukemia, not ALL, which is acute lymphoblastic leukemia. Now, the difference between the blastic and the cytic, here you can see lymphocytes, 77%. If there were blasts, they wouldn't mention them as lymphocytes. They would actually tell you they were lymphoblasts. So that's a big clue. You need to see a high percentage. If it's like around 20% is when I'm going to be thinking, oh, we're dealing with an ALL picture. But a 64-year-old, unlikely to get ALL. It's going to usually be a kid in our situations on exam purposes. And if I'm thinking of myeloid, then it's going to be an AML, which can be older people. But again, the focus here is going to be to give you primarily lymphocytes in this recurrently infection guy. And the big clue I want you to recognize a smudge cell. It's absolute giveaway for CLL. Absolute main thing to understand is, what I remember that is, who gets CLL? Generally older folks get ALL. And older folks are fragile, just like their cells. So when they put that microscope down, they put that film on top of it, it's such fragile cells, they just pop. And you see these like faded looking WBCs on the smear, those are smudge cells. And that's what they're really focusing on here. The one that they just look like they've been squished, and you can kind of see through them, and that's kind of what they're focusing on there. And if you can recognize a smudge cell, if you put that with the story, you have to know the association between a smudge cell and CLL and autoimmune hemolytic anemia. CLL has a high association with warm agglutinin autoimmune hemolytic anemia. It can also be associated with cold, but warm agglutinin autoimmune hemolytic anemia. And that's what the key in this question is. Let's look at the other options and let's try to make sure we don't get confused with the rest are. So the big one that they trapped everybody was blast crisis. Right? These are not blast cells. I want you guys to look up pictures of blast cells and kind of see what they look like. They're just big, angry looking lymphocytes, and you would see it in when they break down the leukocyte count into different types. They will say blasts if they're trying to point towards blast cells. Lytic bone lesions was another one that got a lot of options. That, what are you thinking about? Multiple myeloma. Lytic bone lesions, multiple myeloma, you're going to think more the Crab criteria: hypercalcemia, renal insufficiency, anemia, and bone lytic lesions. Not smudge cells, not this high level of lymphocytes, not painless lymphadenopathy, and hepatosplenomegaly. You can see some of that stuff, but not necessarily what the picture is going to point towards. Disseminated intravascular coagulation, DIC, that goes back to our first question. Schistocytes. If I see schistocytes and if I see any kind of recent infection that's flaring it up, that's going to be the picture that I'm going to go for. More with low platelets and low hemoglobin at the same time. Here, the platelets are normal. That's not DIC. Autoinfarction of the spleen. What am I thinking with autoinfarction of the spleen? This is going to be going down the sickle cell anemia and causing the sickling in the spleen and causing the spleen to necrose itself. And again, you don't see any sickle cells in the smear. I wouldn't go with sickle cell anemia, and it wouldn't explain his lymphocyte count. That's the kind of breakdown of this question. Again, tough question. These weird looking white cells, I get why they kind of look like blast cells, but you have to look at them and they just look like squished WBCs, and that's the goal here. I hope that you learn from this topic here. Very high yield. You would see the big picture and also use the physical exam, use the lab findings, and understand that CLL has a high association with autoimmune hemolytic anemia, particularly the warm agglutinin, which is going to be the IgG. All right, I hope this was a really good question for you guys and you guys learned something. And next time you guys will be able to get this one right.